Welcome. My name is Luis Paz Guerrero, and my topic of today is about Nivolumab versus Everolimus in advanced renal cell carcinoma. Let's start. Definition: Nivolumab, a programmed dead checkpoint inhibitor, was associated with encouraging overall survival in uncontrolled studies involving previously treated patients with advanced renal cell carcinoma.
Renal cell carcinoma (RCC) is a kidney cancer that originates in the lining of the proximal convoluted tubule, a part of the very small tubes in the kidney that transport waste molecules from the blood to the urine. RCC is the most common type of kidney cancer in adults, responsible for approximately 90–95% of cases. Initial treatment is most commonly either partial or complete removal of the affected kidney where the cancer is not metastasized, spread to other organs, or burrow deeper into the tissues of the kidney. The 5-year survival rate is 65–90%, but this is lowered considerably when the cancer has spread. The body is remarkably good at hiding the symptoms, and as a result people with RCC often have advanced disease by the time it is discovered. The initial symptoms of RCC often include blood in the urine, occurring in 40% of affected persons at the time they first seek medical attention, flank pain, 40%, a mass in the abdomen or flank, 25%, weight loss, 33%, fever, 20%, high blood pressure, 20%, night sweats and generally feeling unwell. When RCC metastasizes, it most commonly spreads to the lymph nodes, lungs, liver, adrenal glands, brain or bones. Immunotherapy and targeted therapy have improved the outlook for metastatic RCC. RCC is also associated with a number of paraneoplastic syndromes, PNS, which are conditions caused by either the hormones produced by the tumor or by the body's attack on the tumor, and are present in about 20% of those with RCC. These syndromes most commonly affect tissues which have not been invaded by the cancer. The most common PNSs seen in people with RCC are high blood calcium levels, polycythemia, the opposite of anemia, due to an overproduction of erythropoietin, thrombocytosis, too many platelets in the blood, leading to an increased tendency for blood clotting and bleeds, and secondary amyloidosis.
Okay. Application in medicine. The drugs that are being mentioned are so important to the treatment for the renal cell carcinoma, and this way we could know what drugs is better than other, and what drugs have more adverse events, and what drugs we must use for this case.
For the most part, the mainstay of treatment for kidney cancer has been VEGF-targeted therapies with drugs like sunitinib and pazopanib. But recently, there's been breakthroughs with the approval of Nivolumab for advanced renal cell carcinoma. Now, Nivolumab was studied in a pivotal phase 3 trial compared to Everolimus in patients who had progressed on drugs like sunitinib and pazopanib. The primary endpoint of the trial was overall survival, and the primary endpoint was reached, showing a benefit in overall survival for Nivolumab compared to Everolimus, and establishing it as a new standard of care in patients who had progressed on sunitinib or pazopanib. The other endpoints we looked at were response, and there was a higher response rate associated with Nivolumab compared to Everolimus. But what's most noteworthy is, in addition to the high response rate, many of the responses were durable. with the average or median duration of response of 12 months at the time of the data analysis, and many of the responses were continuing at that point. We also examined progression-free survival, and there wasn't an improvement in progression-free survival over everolimus. I think there's probably a couple reasons for that. One is this phenomena of pseudoprogression, where sometimes the tumor actually gets a little larger. And the other is the mechanism of immunotherapy is different than that of VEGF-targeted therapies, and so some of the responses may be later, or some of the benefit may be in a group of patients who achieve a long-standing response rather than the majority benefit and by progression-free survival.
Okay. Issue applying in Ecuador. Advanced renal carcinoma, ARCC, is one of the most common adult malignancies. Overall survival, OS, without treatment ranged from 6 to 12 months, and in Ecuador, 269 patients were estimated in 2008 with MRCC. The aim of this study was to assess the most cost-effectiveness of first-line therapies for patients with MRCC from the payer's perspective over 5 years.
The trial asked the question whether cabozantinib is superior to everolimus. Everolimus is an mTOR inhibitor considered standard treatment in second line or later therapies in RCC. Cabozantinib is a dual, VEGF inhibitor, also MET inhibitor, and XL inhibitor, and these two important targets have been involved in resistance to VEGF inhibitors and to progression in preclinical models on VEGF inhibitors, as well as poor prognosis. So cabozantinib target multiple kinases, including the VEGF receptor as well as MET and XL. So it's an unmet need. VEGF resistance is an unmet need. So the trial asked the question, is progression-free survival, the primary endpoint on the METEOR trial, superior with cabozantinib over everolimus? And now at the European Cancer Congress, we have the result presented yesterday showing that cabozantinib is associated with a 42% reduction in the risk of death or progression compared to everolimus. This corresponds to a highly statistically p-value less than 0.001. So the trial met its primary endpoint.
Okay. Pros and cons. Pros: an increase in progression-free survival (SLP) for the combination of nivolumab and ipilimumab has been established in comparison with nivolumab alone, only in patients with low PD-L1 expressions in the tumor. Cons: upper respiratory tract infection, decreased appetite, peripheral neuropathy, headache, disease, diarrhea, nausea, colitis, stomatitis, vomiting, abdominal pain, constipation, dry mouth, and hypertension. Conclusion: among patients with previously treated advanced renal cell carcinoma, overall survival was longer and fewer grade 3 or 4 adverse events occurred with nivolumab than with everolimus. Nivolumab was associated with health-related quality of life improvement compared with everolimus in the previously treated patients with advanced renal cell carcinoma.
Well, just to round out our frontline setting data, we have our most recent data presented at ASCO 2013 this year that is on the RECORD 3 study, which was, again, a relatively new design of a head-to-head comparison. And again, I'll ask Bob to walk us through the design of that study and some of the top-level results that have been reported.
Yeah, at ASCO, I think one of the key abstract presented at ASCO 2013 is the RECORD-3 trial. It's a trial that Bob Motzer presented at the oral session. It's a trial that was designed as a sequential trial of sunitinib followed by everolimus versus everolimus followed by sunitinib. And the trial's results have clarity, although the complexity of the trial presents issues. And, well, what does that mean? Well, the top-line results from the trial, which were the comparison of sunitinib first versus everolimus first, in a non-inferiority phase 2 randomized fashion, demonstrated that sunitinib first is the preferred choice. Everolimus and frontline did not meet the criteria to demonstrate non-inferiority, did not have confidence intervals that statistically allowed us to make that statement, and allows the practicing physician to look at that data and say, okay, given the choice between a TOR inhibitor versus a VEGF receptor inhibitor in the frontline setting, I can feel comfortable in the good and intermediate prognosis patient, primarily, of using a TKI first. The challenges with the trial then come in how it was designed. Most of us would have liked to have seen, well, okay, but if sunitinib is followed by everolimus and everolimus is followed by sunitinib, might we be able to assess the sequence compared to each other? And the complexities of the trial did not allow us to do that. There were excessive dropouts. There were people that went off study to receive a commercially available drug, not study drug. And to Bob Motzer's credit, he was unwilling to really speak to the sequence question in the results presented to date at ASCO 2013. So although many of us are interested, and we'll talk about sequencing of agents in a few moments, I think the take-home lesson from the trial is really the frontline data comparing sunitinib to everolimus, which people can now feel comfortable that sunitinib is the preferred choice.
So just to summarize then, that frontline data really suggesting that comparing what would have been a relatively novel use of everolimus in this frontline space to what we'd consider our standard of care sunitinib was not non-inferior, did not meet that endpoint. The recommendation is to stay with our standard of care sunitinib, VEGF TKI, in that frontline patient population. And looking at this sequence trial design, there are challenges. There's, the loss of patients because of the other treatment options available to people at that time was I think, a real limitation in being able to interpret that data.
And it also challenges us when the clinician asks us, or the patient asks us, well, what was the survival in that design? And with the challenges in the design of the trial, we're really unable to speak to survival comparisons between the two arms. So I think that at the moment, based upon what was presented in abstract by Dr. Motzer, I think we feel confident in the choice. I would say the following caveat again for the practitioner, because they'll be scratching their heads and saying to themselves, well, isn't Toracel or temsirolimus approved in the poor prognostic group with previously untreated metastatic kidney cancer? The answer is yes. And how does that then address the everolimus versus sunitinib portion of that trial? And I think the trial showed us that the number of patients that had criteria that were comparable to the original Toracel or temsirolimus trial were small, that Toracel continues to be an option for the poor prognosis patient, and that at least in a small subpopulation of the RECORD-3 trial, sunitinib is also an option for that patient population.
And I would just add another interesting point of that trial for me was in the non-clear cell. So many people have used the retrospective analysis from the Toracel trial of non-clear cell, which was also a small proportion, to say that TOR inhibitors have more activity in non-clear cell. And that's a question I get asked a lot from the community is how do I treat non-clear cell? And again, it's retrospective data, but it was a fair number of patients. I'm not remembering the numbers offhand, but it was a fair number of patients that looked like, again, there was an advantage to sunitinib in that setting. So really sort of for me, the lesson is, retrospective subset analyses are often misleading, and you really need prospective data. And even though this wasn't just in non-clear cell, it was a reasonable percentage and seems to indicate that VEGF inhibition is still preferred in that setting. As you're well aware, there's an ongoing trial looking at sunitinib versus everolimus strictly in non-clear cell, a randomized phase 2 that you guys are leading. So that will, I think, be certainly the most definitive evidence. But some of these interesting subsets of risk group or clear cell, non-clear cell, even within the limitations in small subsets, I think are informative.
Yeah, I would say that because there is heterogeneity even within the the non-clear cell population, right, that it's very hard to reach any conclusions. We have prospective data looking at non-clear cell renal cell carcinoma treated with sunitinib. There's a difference between chromophobe versus papillary in that. So I think the conclusion for this trial really is that sunitinib is probably the choice compared to everolimus in the frontline setting. With regards to the other sub-analyses, they're intriguing but are not definitive.
So Dan, let me just add in here just my flavor on this. I agree with the thing that everyone's saying. I think at the end of the day, this trial proves, as much as in a non-inferiority study can prove, that there is really no role for an mTOR inhibitor for the vast majority of kidney cancer patients that we see in clinic in the frontline setting. Those are the good and intermediate risk. That was the largest proportion of that trial. That's the concern people had over the past several years. So what about mTOR and that population? The data that is the strongest, which still has Category 1, ESMO and NCCN guideline level evidence, is still TOR inhibition for the true poor risk. I agree with Bob that there are some subsets that hint that maybe VEGF inhibitors such as Sutent have a role. We saw that from the original phase 3 in Sutent. There was, I think, 6% of patients with the poor risk features, that it seems to have some activity there. But the largest number by and far has been the poor risk from the TOR-cell frontline trial. So for the practitioners, TOR-cell should be considered as really a preferred option for patients in the frontline setting poor risk. mTOR should not be used in frontline setting good and intermediate risk.
Okay, that's all for today. Thank you.